for being our for today. And I'm going to invite Kelsey Wagoner to come on up and say a word or two about Constellation Behavioral Health. Thank you, Kelsey.
All right. So I'm kind of glad there's no microphone because that makes me even more nervous. I do have notes. If you see me looking at my phone, I'm not texting and not being rude. So Constellation, for you guys that don't know about us, think of it as the umbrella company to 3 different brands. Those brands include BrightQuest Treatment Centers, which some of you in here stated that you have already heard about. Bridges to Recovery, not to be confused with the one in Kentucky, although we love them. We're in Beverly Hills, and Altamira in Sausalito, California. Each of those have a different niche. So for instance, Bridges to Recovery, think of your client who is really struggling in one area or another, possibly white knuckling it through a relationship or a job, something of that nature. They're probably seeing you weekly, bi-weekly, and you know that they might need a step up. Bridges is a great option for them. 12 patients max. So you're getting one-on-one care, great with personality disorders, and awesome with trauma work as well. Altamira, think of your co-occurring client who is struggling with some kind of substance and mental health. We kind of tackle both. This is a 90-day program. However, they can stay 30, 60, or 90 days. It's up to them. And then finally, BrightQuest Treatment Centers in Nashville and in San Diego. This is for the client who is pretty chronic, complex mental illness. It doesn't have to be schizophrenia, but there's several things going on. Think of somebody who might need some life skills added in there and some family work. We can do that at BrightQuest. The average length of stay here is about a year, so it's our longest length of stay. It's very important to note we are out of network, so keep that in mind if you do make a referral. We will do some financial vetting, and if we are not a good fit, we'll give you options that are. I am a social worker by trade and used to work in psych hospitals, so I never want to leave you guys hanging on where to refer clients. But thank you for having me. If you guys have questions, definitely hit me up. My information should be in all those packets. I'd love to grab coffee with you guys or whatever, just to get to know you and what clients you like to see to make sure I'm referring you guys the best clients. Thanks. That's it.
Thank you, Kelsey. So again, our thanks to Constellation Behavioral Health and to Kelsey for telling us all about it. And once again, welcome today. I am delighted to introduce our speaker for today. Eboni Webb, PsyD, earned her doctorate in clinical psychology from the Minnesota School of Professional Psychology. She began her clinical work as assistant clinical director and program director at Mental Health Systems, one of the largest providers of dialectical behavioral therapy in the United States. At MHS, Dr. Webb developed 2 specialized DBT treatment programs for clients with developmental disabilities and borderline intellectual functioning. Dr. Webb is a highly rated international trainer in DBT and is certified in DBT through the Evergreen Certification Institute. In 2010, Dr. Webb opened the private practice Kairos in Middle Tennessee. Kairos, now known as the Village at Kairos, offers diverse DBT specializations, including DBT for trauma-based disorders and co-occurring disorders. The Village of Kairos has expanded therapy programs, better known as restorative services, to include individual and group therapy sessions for adolescents, parents, families, and adults, including pre- and post-adoption services and in-the-moment coaching for clients. I love this next part, so I had to read it, even though she told me I could cut things short. The vision of the Village of Kairos is to help clients build a life worth living alongside a village of practitioners with lives worth sharing. Dr. Webb adamantly believes that it takes a village to restore a single life. Thank you so much for being with us.
Absolutely. All right. Well, thank you. Let me hide some things here. I'm not sure if it will completely go away, but let's hope. Okay. Well, it has been a good minute since I have Bennett MPI, I used to have an office across the street from Scarrett Bennett, which was wonderful, right? But parking certainly was not wonderful. So this is much easier, and I'm truly, truly honored to be asked to come and speak to you all. So the passion that I have right now is learning how to continue to expand my lens through DBT, but also kind of getting a different understanding of what it means to work with personality disordered individuals. Now, you all most likely know that DBT was originally developed for borderline personality disorder. And certainly that is definitely where I cut my teeth. But there were moments in my work as a DBT therapist where I felt that I was not reaching my clients. And so one of my colleagues recommended, hey, you should try sensorimotor psychotherapy. And I absolutely fell in love, and I found the piece that helped me understand and reconceptualize what is it about borderline personality disorder that makes this so challenging. I love the structure of DBT, but there was something missing for me. Okay, so I would say the most adherent DBT therapist would say that there are no gaps in DBT. And I will say that there are some gaps in DBT. So, but I'd love to share with you how I have found a way to integrate these two to really sit with these clients in a different way. Okay. So let's see here. Of course, my technology is sabotaging me right now. So let's just see what's going to happen. All right. Huh.
I know that's how you work.
Yeah. Yeah, it did. Give me just a moment. Even if I can't, I'll just move the laptop around a little bit. Okay, it went to sleep. Looks like it. Oh. I don't know, maybe, but we don't have to. I can just, my controls aren't even working.
This building.
I'm so sorry, everyone.
Maybe stop the screen share and then
Yeah.
share.
Yeah. It could be.
Yeah, stop sharing.
Should I do it again?
Yeah.
Okay. So
And make sure when you do those screen ups, yeah, you can do
that one.
that one, yeah.
Yep. Let's see, because it is registering. It's just not advancing. And I can't use my controls either. Huh.
Maybe you could do it from the PowerPoint without it being in slideshow. Some slideshow.
I mean, I can stop the slideshow.
Yeah.
Oh, I can't.
Stop share.
Yeah. So I'm not sure why something is making it a slave of mine. Yeah.
So this is just from there.
Yeah. It could be the cable.
Go to just your PowerPoint outside of Zoom.
Yeah, it's completely frozen.
Oh.
Well, there we go. Okay, well,
So
there
we
it is.
just can't share it on Zoom, or we could try again.
We could try.
You're in slideshow mode.
Yeah.
Go to your top.
I have no idea. Where do I go?
Well,
I can get out of it. Go that way.
yeah. 'Cause it's,
There's something going on with that.
and now the projector's not even.
Yeah, the projector's not working.
Okay. Didn't even do anything.
I have no idea. None.
Let's try replugging this.
All right.
We just have to do it. Okay. Okay, maybe try one more time
With
for
those
the,
in.
yeah.
It's happening soon. I just used this yesterday.
Maximize it over here. Yeah.
Alright. We'll try that one.
Yeah, and then maybe you can go to slideshow mode. Okay, so I think that's working, so try slideshow from there. And then
We'll
we'll
let you advance.
Yes, okay. Let's do that.
Right.
All right.
Every time.
So let me just be real. I am married to an IT guy who I always have to call for coaching myself because I melt down. So, all right. So we're going to start with an opening mindfulness that I was taught in Sensorimotor. This is by the work of Bonnie Bainbridge Cohen that I find to be incredibly helpful when I start working with clients initially to get a sense of their attachment disturbances. Because if I can have you take away anything in how I think about borderline personality, when you look at the criteria, what you could compare it to is the criteria for reactive attachment disorder. And what I think about borderline personality is that this is the adult presentation of reactive attachment disorder with a healthy dose of PTSD along the way and lots of attachment disturbances. So what I want to do in building my relationship with my clients is to get a sense of how do they sense safety with me in their bodies. So we're going to do this together, okay? So we're going to start with a movement that is our first developmental movement, which is surrender. So I want you to get positioned in your seat in such a way that you are fully supported by the chair. So if that means that you need to extend your legs out, no part of you is just working to keep yourself up, but just surrender to the seat. If it helps you to close your eyes, just start to settle into the seat. And just study how surrender feels in your body. It may not feel comfortable. Try not to get attached to that. Just notice how surrender registers inside of your body. Now we're going to move to another movement. So just take a deep inhale and exhale for me. And now we're going to move into a push. So if your feet have been extended out, plant your feet and press down through your feet. You can also use your hands and press down on your thighs to create a push in your body. It's a different movement, different sensation. So notice how push feels in your body. We're just being curious. Some positions may feel more comfortable than others. That's okay. Now, what I want you to do is imagine that you are reaching out towards someone. Okay, now you can reach out to somebody next to you, but what you're going to do is you're not going to make connection. Just notice how you may extend your reach out to someone. Okay, and notice if as you extend your arm out, is your palm open? Is your palm down? Just kind of study kind of organically how you reach out for someone. Again, take another breath for me. Now let's imagine as you are reaching out that you're grasping onto something. So notice how you grasp, and notice even potentially the intensity of how you grasp. And just study that for a moment. Take another inhale and exhale for me. Now, imagine that what you have grasped onto, you're bringing home to yourself. So put your body into a posture of bringing home. Maybe it's over the chest, maybe it's just dropping your arms. Just notice what it's like to come home to yourself. Breathing in, breathing out. And just for one more movement, I would like you to go back to the movement that felt the best in your body. Perhaps it was the surrendering to the chair, the push, pressing down through your feet, the reaching, the grasping, or the bringing home. And recognizing that this posture is your anchored resource that you can always find in your body. All right, and so let's take another big deep breath. Inhale and exhale. Gonna shake our bodies out. Okay. All right, so these are as Bonnie Bainbridge Cohen talks about, as the 5 developmental movements that point towards how babies learn how to attach to a care provider to be nourished. So as a baby is being held, there's that surrender. And if you've ever held a baby, doesn't matter if you're male or female, they start headbutting you to get into the tap, right? And that push, right? And then the reaching, the grasping, bringing home. So what's very interesting when I do this mindfulness with clients, and I keep drifting from this camera, I got to remember for my people online, I'm sorry. What's interesting is their response, and it truly is a visceral response. And you will get a lot of information about early childhood connection. We work with a fair number of clients in our practice that have come from adoption. They hate surrender. I've had clients actually swear at the thought of doing surrender. Not surprisingly, we have a lot of teens that like push. They like that feel in their body, right? Excuse me, but all of them, what's interesting is the story that they attach, right? The reaching, I always feel like I'm reaching out and there's never anybody there, right? The bringing home, I don't know what I'm coming home to, right? You get so many stories that can help, and also to be curious about your own experience with these movements, especially as clinicians, right? When you may feel this exhaustion with constantly reaching for clients, right? So we do this as a way to open up and begin our work together, but also throughout the course of treatment, these movements also change for clients in terms of how safe they feel in the various movements. All right, so one of the things that I love about the integration of sensorimotor is, again, thinking about this idea of felt safety. And Janina Fisher, she has some wonderful books about this, but what we have to create in our therapeutic spaces are opportunities for safe reparative learning, right? And that is how healing occurs. And that's one of the things I love about this quote, is that we're trying to give our clients that renewed faith in the universe, right? We all come from different modalities, different approaches. And I think consistently the research really points to, it's not about your approach. It is more about the client's perception that you can help them and their therapeutic relationship with you, right? And therein is the rub, especially if you're working with personality disordered clients, and especially more so when we're working with clients that do have the diagnosis of borderline personality disorder, is that difficulty of creating the relationship is so much of the work at the beginning. So I'd like for you, and we're going to talk very quickly about kind of the impact of trauma on developing mind, personality, and the regulation of cortisol stress. And DBT is so strong in this area of teaching our clients how to manage their emotions, where emotions are really shaped through healthy attachment, which most of our clients do not have, right? So I want you to understand how that pattern, right, creates this need for them to pull from us to regulate their discomfort. And then I want to explain to you what I have really been working through and talking through is this concept of authoritative therapy. At the Village, we do a lot of work with families and the family systems, right? And I do love, right? We get parents who are like, Dr. Webb, I think my child has borderline personality disorder. I'm like, well, what's true about the Gosling? We got a gander or a goose who's also meeting criteria, right? So it's, this doesn't come out of a vacuum, right? And so we really want to think about that opportunity to healthily and respectfully reparent our clients into being able to self-regulate. So it's my favorite Rudyard Kipling quote for this topic. I mean, he has many other things I do enjoy. But if you didn't know, Rudyard Kipling came from a very horrible childhood of abuse. And he was interviewed at a point in his life where he was asked, his aunt, the beloved aunt, would ask me why I had never told anyone how I was being treated. Children tell little more than animals, for what comes to them they accept as eternally established. And, if you've read the Jungle Book and thinking about those stories of a child lost in the woods being raised by wild animals, right? Very indicative of Rudyard Kipling's vision of the world. But so many of our clients will come in and they will not see the strangeness of family dynamics. They will not see the strangeness of things, right? Which again lets us know how early the disturbances, how early the traumas occurred in their stories. And so I don't like to think about human beings as being kind of blank slates, but we are in many ways open maps. And each encounter, right, plots out this map. And we don't question it until we encounter somebody else's map that is a bit different, okay? And so that's our challenge as clinicians, to be able to present that as that opportunity. Hey, have you considered this map, right? So in the practice, we ask people, what is your recovery vision, right? How will you know that you have improved, okay? And so our first step is to get them somatically regulated, okay? So there are many different types of dysregulation that we'll walk through. Our clients suffer from emotional vulnerability. Whether you're doing DBT or anything, people come through the door often in emotional distress, even though they may want to treat it logically and cognitively, okay? They are emotionally distressed. And what I like to think about with emotions, that emotions are the language of the body. And most of our clients are emotionally illiterate, okay? But that vulnerability to the emotions definitely predates their walking into our door, okay? And that there are so many sources of that, right? So we can think about attachment issues, even the kind of genetic transmission of that open potentiality for emotional sensitivity. And we certainly encourage our families that we work with to understand that unless you didn't have this child, it's the only way to have been able to control for the sensitivity, right? And so we really want to recognize that innate sensitivity that the client has, but also that they have come from a history of constantly being invalidated for it, being told they shouldn't feel that way, right? They believe they're too much, that they destroy people with their emotions. They have become fearful of listening to the language of their own bodies, okay? And so there's that kind of reciprocal relationship between an environment that is of that strong poorness of fit, not being able to manage the sensitivity and how that continues to perpetuate throughout their life story. So we have certainly emotional dysregulation. It's very important to always remember we are surviving and emotional creatures before we're cognitive creatures, right? So we come into this world with that lower brain, that midbrain ready to go. Survival strategies, that prefrontal cortex, right? 25 years, which makes us neurobiologically the most vulnerable organisms on this planet. Okay, so we learn to connect emotionally initially. So if we're already dysregulated, we're going to have interpersonal chaos. Okay, and if we cannot be in healthy relationship with others, we lose our sense of ourselves. It's an interesting paradox that we come to know ourselves through the context of others. Okay. Certainly, I think DBT excels in the areas of behavioral dysregulation. But when we think about the progression of dysregulation, we've got to figure out a way to soothe all this intensity. So behavioral dysregulation initially in our treatment is always going to be looking at it as a coping solution, right? But as the emotions and the body go, so the mind goes. And so we have worked with many clients that are brilliant, absolutely brilliant, but they cannot handle, say, the rigors of high academia because emotionally they're so compromised, right? And so this should not be a surprise that many of the clients that we serve are artists, and they're very, kind of avant-garde because they just can't work within that structure that, again, aggravates that sensitivity, okay? We also want to recognize that in the first 6 months of life, the parts of the brain that control and regulate cortisol are completely wide open. So it matters if you have clients that are coming from adoption and agencies where there were lots of babies and not enough care providers to soothe. Babies are heavily dependent, especially on the first 6 months of life, of receiving proper co-regulation to allow cortisol levels to lower, okay, because they don't naturally do that, okay? So cortisol is neurotoxic to the hypothalamus. It creates neuron death. It also clogs the corpus callosum. And so the left and right hemispheres are not firing. It messes up bilateral movement, okay? And so stress is not our clients' friends, right? I've had many adult clients with borderline personality who'll say, Dr. Webb, I love being a nurse. I just don't think I can handle it. I'm like, nurses are stress on steroids, okay? And so I get that care providing piece, but the stress alone is what is breaking you down, okay? And from this, of course, our clients are going to be more vulnerable to illness, okay? We all know when you're under a lot of cortisol, right, your immune system gets compromised, okay? So it's not just a mental issue, right? It is a somatic bodily issue. And that if you have clients that have had long histories of being abused, over time, the brain doesn't even know how to respond properly to cortisol, right? And it just clears. It doesn't clear. Sometimes an actual threat has a lowered response over time, right? So we want to definitely be committed to keeping our clients' brains at rest, okay? So the amygdala certainly is where cortisol is going to be flowing, okay? It is the most neuroplastic part of the brain. So as clinicians, if we can bring techniques, skills, mindfulness to keep this part of the brain at rest, it can rebound, okay? But the amygdala is 100% reactionary, okay? It is going to trigger the sensory system. So hold, that smell and touch are going to be the most direct pathways to activate and deactivate a stress response with your clients, okay? And it controls all the autonomic responses, right? So our clients are so hard on themselves. I wish I could do this differently. I don't understand why I keep doing it this way. Our clients are getting emotionally hijacked in session, out of session, and the parts of the brain that take that over are not the organizing, planning, thinking parts of the brain, Okay, so we want them to kind of create these gray spaces. Okay, and this is how I do it, right? So I'll ask, and we do this in our larger groups. When you have been emotionally aroused over time with no relief, right? And you don't even have to have innate sensitivity to know what that's like to be up high, and not being able to come down. How do you come down? Now, typically in groups, I will get people, like if I'm talking to therapists, they're like, I'll meditate, I go for a walk, I call a friend. And then there's always one therapist who is honest. And they're like, I drink bourbon, right? If I'm in the South, they'll say I drink bourbon, okay? Other people, I'll Netflix and chill, right? Okay. So even the things that have so much skill to them also can become problematic, right? Because how many of our clients over-exercise, right? For my people who say, well, I clean when I'm stressed. Well, there are a lot of people who distract from all other tasks to clean, right? The point is that we all find ways to get out of distress, okay? And so we want to create this kind of normalizing bridge for our clients that feel so alien and so strange, okay? So all babies start out dysregulated. That's why we don't remember birth, okay? Birth is dysregulating. We need co-regulation in order to move to self-regulation. And this is something else that I have found, even with my adult clients, they do not know how to self-regulate. And they often have behaviors that would suggest that they've lost the sense of object permanence. Okay. And so I have done a sensorimotor exercise with a client where I have like a stool that swivels. And I wrap a rope around my waist and give the end to my client. And I describe to them what I'm about to do. And I'm going to tell them that I'm going to start turning away from you. And at any point that you start to feel distress, you can always pull me back. And we're going to work this until I'm completely with my back towards you. And let me tell you, most of my clients, when I describe this, they start to have a panic attack about it, even in the description. And so we start slow until they finally realize, like, I can always pull Dr. Webb back to me until they can tolerate not seeing my face. And that just blew my mind when I started to do this, but it increased this sense of awareness that it's not enough to talk through things. They get it in the session, but we've got to have strategies to kind of weave into their somatic system these lessons. Okay. And so working on helping them get to self-regulation, because the goal is not to be co-regulating forever. This piece I love about DBT, we work ourselves out of a job, okay, which is very much a mirroring of parenting, okay, but you have to have strategies where they can sense the safety of self-regulation with you. Otherwise, you get where you have these great sessions, and as soon as the client gets out to the parking lot, they're texting you, that was the worst session I've ever had. I felt really judged by you, and I'm never coming back. Now, of course, they're going to be back next week, right? But still, they're so angry. But a part of that is that they've left the co-regulation, and they're terrified. They're terrified of having to self-regulate. And what most of our clients have learned, that co-regulation comes with dysregulation. So let me put the house back on fire. Okay. So that's why we're trying to break through some of this. So this is very typical patterns of healthy parenting, right? Where we are setting our intention to be attuned, to use facial contact with a baby, using communication so that we, can start working on that sense of self and other. But also whenever there's a rupture, right? Parents work on repairing, okay? Where there's no repair and there's just punishment, then we are moving into trauma, okay? Most of our clients have no idea what it's like to have healthy repair. We're going to wound our clients. Our clients expect us to traumatize them more than wound, right? And they have very low tolerance, okay, for any type of rupture. But what's important is that we're not perfect therapists, but we learn how to perfect our repair. Okay. And so what we want to then target, of course, is self-regulation. And the beginning of this is our social engagement system, making eye contact with each other, right? Human beings, our neurological development is based upon eye gazing and language, which is very concerning in this technological age, okay? We're losing this kind of eye-to-eye contact, okay? But these are two very unique aspects of how we regulate as a species. Our pitch and tone of our voice, how we utilize touch, okay? These are all aspects of our social engagement system and proximity. I'm going to give you some tools at the end of this talk where proximity becomes very important of how you set up your therapeutic space, okay? So this is what I mean by secure and authoritative therapy, right? We want our clients to become autonomous and interdependent, okay? The hallmark of adolescence is dependence or independence, okay? Childhood is dependence, adolescence is independence. The goal of adult life is interdependence, right? Knowing when you need help and knowing when you can do something by yourself. And most of our clients have not been launched into interdependence, okay? We want them to experience the power of autonomy and agency, but that comes through this kind of secure and authoritative therapy, okay? Remember, authoritative parents have high structure, they have high expectations, but they have moderate communication. They're attuned to the level of communication based upon the regulation of their child. Okay, so they don't over-explain, that's kind of the permissive parent, or they don't under-explain like the authoritarian parent, right? They're the Goldilocks, they get just right, okay? But also they know how to make repair, okay? Because they know that they're not going to get it right, right? And so that is what we're modeling in our work. So I'll put this up really quickly. These are all the areas, right, that constitute secure attachment. And in the next slide, I will show you how this transfers into the therapeutic space, right? So we want to keep that safe harbor, the secure base, proximity maintenance, and also that kind of social connection, right? We connect bodily and mentally. How you even physically show up for your clients matters, okay? So with authoritative therapy, right? We have our therapy as our safe harbor. If you have clients that maybe cannot be in their homes, they have that sober housing or family. We look at secure bases. Within an addiction model, you want sponsors, recovery groups, skills groups, or that secure base. That's what I love about DBT. We have a totally separate skills day where you're developing that kind of recovery skills group. Proximity maintenance with coaching, okay? Case management is needed. And then when we think about even like sobriety, and I'm going to talk about this, our clients have to get even emotionally sober, right? Because if they do have any type of chemical dependence, there is a level of sobriety which is about getting clear, right? So we want their bodies holistically balanced and their minds equally, okay? So as the body goes, so the mind goes. And so this is where we come in as therapists and also having proper physicians to assist in our care. So if you all are like, oh, it's a lot. Yes, it is. You're doing a lot of work, okay? And this is why I like the approaches that DBT offers as well as Sensorimotor, because we are truly trying to build a village around the person, okay? So mental clarity is important, okay? Our clients often don't know the difference anymore between trauma and attachment disturbances. And if they've happened early developmentally, then that makes a lot of sense. But we still want them to get to a clear state of mind, okay? So most of them will say, you know, it didn't really happen or doesn't matter at the beginning. And the reason they're doing that is because they've got all of these various coping solutions, right? All of these different ways to cloud that it didn't really happen. Okay, even if it is, I'm really sensitive and I need to do all these things to get away from that sensitivity, even though it's not going away, right? Our work is to take those clouds away to move to, no, it really happened, or something really happened to you, or you really do have this innate sensitivity. But when we take those clouds away, right, here comes the pain, the shame, all these emotions, okay? And we do have to provide replacement skills and ways to help regulate that storm. Our ultimate goal will be to get them to embrace in this radical acceptance. Yes, it really happened to me. This is really who I am, right? That facilitates that healing, that hope, right? This new sense of self and finding their voice, which is probably my favorite thing to help clients discover. So for you, when we're doing relational surrender, what does it look like for our clients to surrender to our care? Well, they need to be body-centered and grounded. So absolutely, we endorse physical movement, both in DBT to regulate emotions. Certainly in the work of Dr. Bessel van der Kolk, he recommends like trauma-sensitive yoga, things that help the client land in their body. And since we foundationally established in DBT, utilizing mindfulness, that has to be the central point of your therapy. And if your clients lose the present moment, to not hesitate to come back to mindfulness again and again. There is no learning in the survival parts of the brain. Okay, either the brain's at rest or it's not. Okay, we want them to be emotionally regulated, to recognize that their emotions are here to serve them, not to enslave them. Okay, and to not underestimate the illiteracy. So teaching them, this is how anger shows up in the body. This is why anger shows up in the body. This is why shame shows up, right? And so people who work with me know I do lots of rhymes, and I will blame on the record here my husband, because he is also a Baptist minister, and you know Baptist ministers like to rhyme, okay? He practices preaching with Dr. Seuss. It's hilarious, okay? But what I'll say in group is you cannot tame something that you can't name, right? The naming begins the taming. And so we really work with clients to learn how to name those things, right? Recognizing, like Brene Brown says, that we cannot just pick the emotions that we want to have, right? We're going to numb all of them, but also the ones like joy and love, those emotions that we really desire to maintain. All right, so here are your toolkits, okay? We want to give you something to take away, okay? So when we're thinking about authoritative therapy and that proximity maintenance, boundaries become very important, okay? So you want to think about your clients almost like thinking about the outer wall of a cell that has three major functions. One, it protects the cell, it screens, and it contains the cell. Most of our clients will be either over or under in this area, right? Very overprotective, right? Therefore, no need to screen. And, you know, they're very self-contained, and that can be a client that can be very hard to get a sense of what's landing, or the underbounded, underprotected, the clients that don't screen. And therefore they don't have much of an identity because they have no sense of containment, right? And I'll show this to clients and they will be like, yep, that's me. That's me. This is the area that I have a problem with, right? And so we have to model healthy boundaries to our clients, okay? So when we are being attuned, that's the part of when we're thinking about boundaries and being attuned to clients. You want to look for, and these are some of the areas that we examine in dialectical behavior therapy with our dilemmas. You're going to have clients that are going to be self-haters to people pleasers, right? Perfectionists to procrastinators. And it's all pointing to self-invalidation. With the emotional vulnerability, you may have that wild and raging client, but you'll also have the client that communicates they cannot handle anything. It's too much, right? You'll have those, especially if they have PTSD, where they're actively checked out, right? Or just, I don't want to talk about that, right? So it'll run that continuum. So when you are being attuned, right, you've got to use your body and even what your body is telling you about what's happening in this moment to think about how to intervene. So part of it begins with your communication, okay? You don't have to go in and, obviously not touch your client unless that's been agreed upon, but learning how to control and regulate your tone of voice, right? So it's not uncommon for me, if I'm very aware that we are maybe not present in our body, to start asking some questions of my clients in a tone that is non-threatening, okay? Or I may raise the pitch of my voice if I'm aware that they are really, really gone, okay? The intonation, right? The rhythm of my talk, right? The kind of loudness, we have to be really mindful of that if our clients have come from homes where they have been yelled at. Our clients may be more sensitive to that and have what we think of as a false anger alarm, where they think you're yelling at them, right? But please be mindful, right? That clients that have come from abuse may be very much more attuned to your emotional state than you are, because that's what they've had to do for survival, right? I've had lots of clients like, Dr. Webb, I think you're mad at me. And I'm just like, no, I'm not. And then I'm like, wait a minute. Yep. Yeah, I am. Okay. So need to do a repair. Okay. But that's important, right? To be aware, again, this is how we start to engage with each other and being able to work even in how we are communicating what's happening real time in the session. Okay. That stress and that pressure in our voice, right? So that's one of our tools, okay? So when we're working with self-invalidation, you're communicating, right? You're modeling failure, right? Especially if there's this sense that they feel like they're not getting it right. It's like, you know what? It makes sense that you would feel that way, right? It makes sense that, you are sensing that I'm angry at you, right? I messed up. Let's do that again, right? If you can't come off of your pedestal, it does not give the client the permission to, okay? Learning how to model self-care, helping them create a safe home environment, right? As we treat our body, so our emotions go. And learning how to model emotions is very, very important, okay? Our clients are used to exaggeration. And so we start to model how an emotion can show up, right? I can be angry without yelling, okay? And so we're doing all of this to be very attuned to help kind of create this sense of safety, okay? Now, your space is that safe haven, okay? So we'll just put these up here, okay? The different areas that I would highly recommend that you are being attuned to. I initially set my therapeutic office up because I thought this was feng shui, this was going to be perfect. And it's a mess for clients, okay? And when I'm working with clients now with this, I'm very attuned that sometimes I am so far away from them just by the kind of layout of the room that it gives them more ease of dissociating or checking out, okay? Now, I also have some clients, and these are adult clients who's like, Dr. Webb, if you let me, I'd sit on your lap. And I'm just like, well, no, we're not going to do that, right? But I have different levels of seating, and I allow my clients to choose where they want to sit and where they want me to sit. And we will do a little proximity exercise to kind of figure out how close is too close and how far is too far away for you. And it may change session by session, okay? Windows, lighting, right? Keeping them fed, right? But also when we think about smells, remembering about smell and touch, these are a lot of the pieces that I'd recommend that you put in. But the olfactory bulb, one of the oldest structures in our brain, very close to the hippocampus. So it has to be perceived as a regulating smell, okay? You may like lavender, okay? I have plenty of clients who love patchouli. I hate it, y'all. Hate it. When I think of patchouli, I think of Bonnaroo and like dehydrated hippies and tents. Okay. I just cannot take patchouli, right? It is not a regulating smell. So don't assume, okay? Don't assume that the smells that you like keep your client's brain at rest. So we do a lot of collaboration. And that's a large part of even pre-treatment for DBT is collaborating on how are we going to enter into work together. Okay. Now, we all know validation is foundational. So with our clients that are going through crisis, they're in that what we call active passivity. It's the help, reject, and complaining, right? You need to help me. You give a solution. Oh no, that'll never work. Okay. But you need to help me. Okay. And then a lot of them also will come in with this high apparent competence. I'll never forget when I was being trained in Minneapolis, there was a client who would come to group and she had Marsha Linehan's DBT book. And all throughout group, she would say, oh, this is not how Marsha would do it. Okay. So, and I'm just like, wow, there's so many things that Marsha would not do that you are doing, my friend. Right. And so that high disconnect between what they're saying and what they're doing. But they've also been fed this language, you know, you're so competent at work, why can't you be competent at home? Right. And so we really want to get out of those areas, right? And validation is one of the ways where we can start, you know, helping them make sense, right? We can cheerlead them, we can help them move into proper problem solving, right? We lose the assumption that they should behave in all contexts based upon one, right? It makes sense that you are extremely competent at work because you need to get paid, right? And at home, you're far more emotionally compromised. Yeah. And at the end of your day, yeah, you've been building up so much, right? So when we are learning how to help our clients break through these dilemmas, we're doing it through modeling to them. First, you model it, and then over time, it becomes internalized for them, right? I can do this, okay? So I want you to know that stress response is learned, it's neurobiologically driven, and it's socially maintained, right? So when we think about DBT, I also would want you to consider if you are doing some type of somatic body-based work, it can be very helpful in treatment, whether you're doing EMDR, but even walk-in talks, getting your clients moving, okay? Attachment is critical to every organism's survival, but as Dan Siegel would say, it's not so much about survival of the fittest, but those who figure out how to fit, right? And to let go of the idea of our clients engaging in attention-seeking behaviors to looking at them as attachment-seeking behaviors and being attuned to what are they trying to get me to attach to with them, okay? And we make arbitrary distinctions between the mind and the body. The body just doesn't work that way, right? It isn't an either or, but a both and. All right, so I want to, and also that we are complex creatures. Therefore, one strategy could not possibly fit all. Okay, now don't tell Marsha Linehan and her camp I said that, but we need both approaches that deal with the cognitive as well as the somatic to really get the body healed. Okay, so never underestimate the tools that you already have to integrate into the work. Okay, so I want you just to conclude here. I want you to go back to that position that felt the most comfortable in your body and close your eyes. I'm going to leave you with a quote from Ron Kurtz, who definitely influenced sensorimotor psychotherapy. He is also the creator or was creator of the Hakomi method, another somatic approach. And this is what he said. And as you rest in this position, listen to these words. The impulse to heal is real and powerful and lies within the client. Our job is to evoke that healing power, to meet its tests and needs, and to support it in its expression and development. We are not the healers. We are the context in which healing is inspired. Recognize that again. The impulse to heal is real and powerful and lies within your client. Your job is to evoke that healing power, to meet its tests and needs, and to support it in its expression and development. You are not the healers. You are the context in which healing is inspired. So with that, I know we only have a few minutes. If there are any questions, I also will be around after to address those questions. But are there any? Yes.
You're talking about the authoritative,
Mhm.
I guess, voice. What would, how would you describe that state?
Yeah, great questions. The question, just for our people online, is, how would I describe the stance of that authoritative therapy? Yes. And so the stance needs to be that whatever treatment you're doing is very clearly structured and predictable, right? And so in the therapeutic relationship, what we'll agree at the outset is, if this happens, then this needs to happen, right? So that they don't have to deduce, right? They know exactly, if I do this, this is what will happen, right? And so there's that high structure, the expectation that you are cheerleading them, right? You're coming in with the belief that I know you can do this, but you're also structuring your approaches and that with moderate difficulty, right? So make sure that it's not beyond their grasp, but being able to attune that sometimes we do take those 5 steps back. Well, I'm going to take those 5 steps back with you, right? And then we're going to walk together to get to that post, right? And then the moderate communication. If my clients are super dysregulated, I keep my interventions very clear, right? We can take a moment to lower our voice, or like if I'm coaching, I'm going to have to hang up. You choose. And I wait, right? And these sound like interventions that you'd have with kids. These are great for kids, but this is a lot of my adult population that I've worked with in DBT, right? And so that's that moderate communication, right? So does that help? Great, great. Any other questions? Well, it is such a pleasure to be able to come before you all. Thank you so much for the opportunity. Thank you, everybody online, for the patience through the tech problems, but we made it. So thank you again.
Chat, there may be a question.
It was, thank you.